Okay, good evening. My name is Olivia Lee. I'm a faculty member at UC Irvine, and my specialty is cornea and external disease as well as uveitis. So I'm going to kick off tonight's lecture on ocular oncology, and I'm going to talk to you about ocular surface tumors. So you may not even know what that even means, but I'm going to start with the surface of the eye, and then our other two speakers are going to go around the eye and in the eye. So we're first going to start with the surface of the eye, and here's the outline for my part of today's lecture. So number one, what is an ocular surface tumor? And then we're going to talk about benign versus malignant tumors, how we make the diagnosis, and then talk a little bit about treatment. So when we talk about the surface of the eye, you could just think about it as any part of the eye that is not inside the eye, but the air can touch. So that's what we call the ocular surface. So in this photo, you can see here's the cornea, here's the conjunctiva and sclera, the underside of the eyelid. I'll leave the actual eyelid skin and the structures around the eyeball to Dr. Ediriwickrema for the end of tonight's lecture. But I'm going to concentrate tonight about the conjunctiva. So if you imagine that the surface of the eyeball and the inner aspect of the eyelid is covered with a very thin, transparent skin, different than the skin that is on our face, on our body, but there's a transparent skin that's on the surface of the eye. That's primarily what we're going to be talking about tonight. So for example, here is a very typical lesion of the conjunctiva. So you can see this triangular or wing-shaped structure, and it is because this normal tissue here has grown across the cornea over here. The layman's term for this lesion is surfer's eye. We call it a pterygium. This is a benign lesion, quite common in surfers or people who get a lot of sun exposure. And this one is a particularly large one because it's grown so far across the eye that it's actually covering the pupil. Very few people in this country let it get this far before coming to see a doctor. Whereas this one is a malignant tumor of the same tissue, the conjunctiva, and you see this very large mass. And it has grown so large that it's covering over 180 degrees and extending onto the cornea. So let's talk about, if we look at a tumor in the conjunctiva, what could these things be? There's actually a lot of different possibilities. There are benign lesions. Some are very common, like the one I just showed you, the pterygium. Some are less common. There are pre-malignant or pre-cancerous lesions, meaning there are cancer cells in the lesion, but the cancer cells haven't extended past that tissue. And that's when we call it malignant, when it's truly a cancer. And there are different kinds of cancers that can grow on the surface of the eye. So melanoma is one of the bad ones. We don't like making this diagnosis. A squamous cell carcinoma, you've probably heard of that. It can happen on the skin, as can melanoma. These squamous cell carcinomas are more common, and thankfully they don't spread to distant sites like brain, liver, or other organs. But when they spread, they can grow quite large if untreated, like the picture that I showed you previously. And you can also get lymphoma on the eye as well. So let's play a little game, benign or malignant. So I'm going to show you two lesions and see if at home you can just, in your mind, guess which one is benign, which one is malignant. So on your left, you have this bigger lesion, again, like a wing-shaped lesion, a lot of blood vessels in it. And then the one next to it, I had to put the blue arrow to show you because it's kind of small, little white bump, not quite as red. So actually, both of these are benign. This is what we call a pinguecula. It is a benign tumor of the conjunctiva, also from sun exposure. And if this person just continuously gets sun exposure, the eye remains very inflamed, it will eventually grow across the cornea and become a pterygium. So this can evolve to this. And generally speaking, these are benign, although there are some of these pterygium that can develop areas of malignancy within them. So, for example, what's the difference between this picture on the left and this picture on the right? So the picture on the right, I already told you, is benign. The picture on the left is actually pretty much the same lesion. It's a pinguecula, this whitish elevated lesion. Many people have pingueculas. They don't even really notice them for the most part because you can barely see this little white growth when you look at yourself in the mirror. Of course, I'm showing you highly magnified photographs because we take these photos using the slit lamp microscope that we have in our office. The difference is this little frond of tissue that has grown past the what we call the corneal limbus, that usually is a separation between where there is conjunctiva, where there isn't. And just the appearance of this frond-like tissue, this is kind of worrisome to me. And so I think this is probably a pre-malignant lesion. How about these two growths? Let's say they're both in children, and this one is like a light brown or fleshy pink. And let's say this 13-year-old, the parents report that they think that this thing is getting bigger. Or how about this dome-shaped, round, smooth lesion that the parents say has been there since birth? These are actually both benign. The fact that something is growing usually signifies to us a risk factor for malignancy. We are worried when the patient tells us something has been growing. In this particular case, this is a benign lesion. It's actually a nevus, or kind of like a mole. And these moles can grow even though they're not malignant. And the typical time that these things will grow is in childhood when the kid is growing, especially in puberty, or the other time is during pregnancy. These are benign. Some patients are worried about them. They don't like them, and it can be removed for that reason, but it doesn't have to. This is a limbal dermoid, and oftentimes these children do have them removed because not because they're malignant, they're totally benign, but because they cause pressure on the cornea in one area and can induce significant amount of astigmatism, which affects the child's vision. So we can do surgery for these, but not because they're malignant. Okay, how about these brown spots? We call these pigmented lesions, and they can be flat, they can be elevated, they can be small, they can be large. This one's more dark than this one. Both of these are actually benign. It's not the darkness of the pigment that makes it more dangerous or more likely to be a melanoma. There are certain characteristics to both of these lesions that make me not so worried about them. And I will also add that the photo on the left is from a Vietnamese middle-aged woman. Why is that important? Well, I think that in certain races of people who have more pigment in their skin, in their hair, it is okay to have these brownish lesions. And in some cases, there's much more extensive brown pigment on the eye than even this photo. But if I changed the scenario and told you that this was a, blonde-haired, blue-eyed, light-skinned person, then this pigment would be more concerning. In this situation here, I can see there's little hair follicles in there. That actually is a good sign. How about these two photos? So this one is, again, darker than the one we showed before. And these are also dark. So the one on the left is also a nevus, and I'll show you in a later slide how I was able to confirm that. And the one on the right is actually a patient that Dr. Mishra and I are taking care of right now, and the jury is still out on that one, but we were worried that this is a melanoma. And I'll say that when we're not sure, based on our clinical exam, we recommend taking a tissue sample or a biopsy so that we can look at it under the microscope. How about these two lesions? Neither one of them is causing the patient any pain, and the patient, in both cases, kind of incidentally notice them, because you'll see in the picture on the left, the reason you don't see, the pupil is because I'm asking the patient to look all the way down towards the floor, and you don't see it up here. There's a finger pulling the upper eyelid up. So this is very far up on the eye, where when the patient looks in the mirror, they don't see this. And in this situation, also, there's a finger pulling the upper eyelid up to take this photo. But when the patient is normally looking straight in the mirror, they're not really seeing this. It wasn't really until it kind of started to encroach on the pupil that it started to affect the patient's vision that they noticed it. Well, the one on the left is definitely malignant, and there are features of it that when I look at it, of course, under this high magnification, I can tell that it's malignant. The one on the right, I thought it was malignant, and I did a surgery with the assumption that it was malignant, but actually the specimen, when it was sent to the pathologist and the pathologist looked at it under high magnification under the microscope, told me that this was actually a non-infectious inflammatory lesion. So my point is that sometimes you can make the diagnosis by looking at features of the lesion just with high magnification and looking in the office at the slit lamp. And sometimes you really need to take a biopsy and have it looked at by the pathologist to know the difference. Here are two lesions that this one was actually an infection and not a true tumor. And, I wouldn't be able to look at this picture and tell you that. It is because there was a story behind it where the patient had a retinal detachment, and then they had a surgery to fix that retinal detachment. A foreign body was placed in the eye called a scleral buckle. That's one method that is used to fix retinal detachments, where it's kind of like a belt is put around the eyeball. Well, that belt got infected and it was removed. And when that foreign body was cultured, we found out that it was growing a certain type of mycobacteria. It's a bacteria that's similar to tuberculosis. And when that patient was treated with antibiotics, this thing just melted away. So that's definitely not a cancer history. So this one turned out to be lymphoma. And the characteristic appearance of a lymphoma, we call it a salmon patch lesion, is because it has this like salmon colored characteristic to the lesion itself. And, this won't cause pain. The patient might notice it. Sometimes it's way down in what we call the fornix. We have to actually pull the eyelid down to see it way deep underneath between the eyelid and the eyeball. How about these two? So here is a clear, like bubble-like lesion. The patient might feel it when they blink, and they might actually feel it moving around. Or this very pink, smooth nodule. Well, this one isn't a tumor at all. It's actually just a cyst. And sometimes these form because there's lymphatics get filled with fluid and is not even a tumor at all. It's just filled with fluid. Whereas this one is a pyogenic granuloma, which is just a fancy way of saying it's a kind of a scar tissue. And usually we treat these with steroids and they melt away. So how do we make the diagnosis of what kind of lesion this truly is? So like I said, sometimes there's a characteristic look to it that just by experience, we can recognize immediately. Just in the same way that, a person who knows a lot about certain kinds of animals can, there's going to be a characteristic look to a horse versus a zebra that you definitely can tell. And then some people will find that they're, you look at it in the mirror and you can see it, and that is what brings it in. And other patients, it'll be another doctor, like an optometrist, will have seen something and isn't sure, and then so they'll refer it. And sometimes even I can't tell, so we need to do some other examinations. So some things that we can do right there that day in the office that might give me some clues is this So we have these rose Bengal strips. So it's a kind of dye that's on this paper strip. And I just add a few drops of fluid to that strip and apply it to the eye. And I warn the patients, I'm putting this like magenta-like fluid on your eye. When you leave here and you see like your eye is neon pink, this is my fault, okay? And it's just temporary. But what happens is that the pink dye will stick in certain circumstances. And one of those circumstances is when the cells tend to be malignant. Now, there are other circumstances that can also cause the pink dye to stick. So not everything that's pink is necessarily malignant, but it definitely gives me a clue. And so I showed you this earlier where I said this thing looks very benign, like a pinguecula. And you see that there's no pinkness or no pink dye sticking here. But some of this frond-like material that grew past the limbus is staining with that pink dye. So this is what concerns me. And I think that probably this was a benign lesion and it transformed over here into a malignant lesion. And you can have that. You can have a benign lesion that part of it becomes malignant. Another tool we have in our office is a imaging device called an OCT. So this is a non-invasive imaging device. You just put your chin here, your forehead here. This device does not touch the actual tissue. It doesn't touch your eye. You just look in the direction that we ask you to look, and it takes some cross-sectional photos. For example, here, I showed this lesion before, this brown pigmented lesion, and we take a cross-sectional image with the OCT, and you can see there's some black spaces. So these are empty spaces within the lesion, and that means that there are little cysts inside the lesion. The presence of cysts in a pigmented lesion like this suggests that it is a nevus. So this makes me feel a lot better that this is benign, and we just watch it. We just take photos like this. High magnification photos are, a photo is, a picture is worth 1,000 words, right? So before we had the easy ability to take pictures, we would just draw these or measure them, and that is not as great way to serially, longitudinally watch these as just taking pictures. Then the next time the patient comes back, I look at their eye, I'm looking at the old picture, and I'm comparing. I could take a new picture, put the two pictures side by side. As compared to this patient who has a fleshy pink growth. I'm sorry, I'm showing it to you in black and white here, but this growth appeared 3 years after already having had surgery for a brown pigmented lesion in this, 6 o'clock area, 3 years prior. And the patient had no pain. This wasn't brown, and the vision was still 20/20. She wasn't worried at all. But when I looked at it, I was very worried. And I did this cross-sectional image here. And you can see the normal tissue has a dark gray color to it. But this area here, which corresponds to this area here, is more of a light gray. And the thickness of that tissue here is very thin. The thickness here is very thick. So that worried me, and so I biopsied it, and it was a melanoma. So when we are worried and we're not sure if it's a malignant tumor, or we want to confirm that it's malignant, or we're not sure what it is, we want to get tissue so that we can send it to our pathologist. And that's the gold standard to confirm these diagnoses. So you want to take a biopsy, and then you can look at it under the microscope, and under high magnification, you can see the malignant cells. And so this star is showing you that there's a characteristic look to when the tissue has been exposed to a lot of sun. That by itself is not malignant. It is the cells themselves that sometimes there's a characteristic look to the malignant cells. And then the next thing we look at is how malignant are they? Do they have severe metaplasia? So you're looking at two of the cells circled here have particular characteristics that tell us that they're undergoing rapid mitoses, which means like the cells are rapidly dividing. And then there are special stains that the pathologist can apply to tell us exactly what kind of cells. So this particular dye here, if the cells are stained red, then that makes us worried about melanoma. So let's say that we are worried about a malignant lesion. What are the treatments that are available? Well, first, before we talk about treatment, I just want to make the point, and just to all of you, that we are very worried that sun exposure is a risk factor for maybe not all of the lesions I talked about, but many of them. And so I want to stress to you that sun protection is very important, especially here. We live in Southern California. We have great weather. Year round, we can go outside and enjoy our nice Southern California sun, but please protect your eyes. Whether it's winter, whether it's rainy, whether it's snowing, or whether it's cloudy, just please always wear your sunglasses. So this is me and my daughter just last week. And it doesn't matter if it's hot outside or if it's cold outside, please wear your sunglasses. I'm seeing so many patients with these kinds of lesions that I'm worried are pre-malignant or malignant that tell me, oh yeah, I grew up here and, I was a sailor, I was a volleyball player, I was a surfer. And, for decades, we never wore sunscreen, we never wore sunglasses. But we know better now. So at all ages, I recommend, sun protection. So sometimes these benign lesions, we don't need to do anything. We just watch them. Again, UV protection, sunglasses. And occasionally the benign lesions, we offer surgery, but not because it's malignant, because it's growing, because the patient doesn't like how it looks, or because it's causing irritation. When it comes to the malignant lesions, first, before we even talk about treatment, we may want to confirm the diagnosis with a biopsy. And in certain cases like melanoma, we want to know if it's spread beyond the eye. If the tumor is on the eye only and hasn't gone past the eye, and it's only on the surface of the eye, not on the eyelid skin, for example, we can treat it with chemotherapy eye drops. Or we can discuss the possibility of surgery. So when it comes to surgery, we're talking about excising the entire thing. We might call that a biopsy, but to be clear, I don't mean taking a tiny portion of it, but taking the whole thing and a rim of healthy appearing tissue around the lesion, just to make sure we got the whole thing. Here I put plus or minus adjunctive therapy because I want to make the point that there are certain treatments we can do at the time of surgery, like applying a freezing treatment, for example, that sometimes we do. So here are my take-home messages that I will leave up on the screen while I ask if anybody has any questions for me. If not, then I'm going to pass the baton to Dr. Mishra so he can continue, and we'll all be back at the very end in case anybody has any other questions.
Thank you, Dr. Lee. Good evening, everyone. I appreciate everyone, coming here to learn a little bit about some things that can happen to the eye, and not to make it too much of a scary topic. I think it's really all about awareness with a lot of these conditions, and it's just sort of worth discussing a little bit of it in case you come across this or have someone that comes across this. Again, my name is Kapil Mishra. I'm a clinical assistant professor of ophthalmology here at UC Irvine. I'm a specialist in retina as well as ocular oncology. So my talk is specifically on cancer in the back part of the eye, and I'll talk a little bit about sort of the different compartments of the eye. And Dr. Lee so eloquently covered the surface of the eye, and I'll delve a little bit inside the eye. So it's worth just stepping back a little bit and kind of thinking about our field. And when we think of oncology is such a large space in the medical field, and ophthalmology is so localized and so secluded really from the rest of the body. But ocular oncology, I would like to think, is a little bit of an intersect between the two, because anytime we see a growth in the eye, there's very much a possibility that it either came from somewhere else or it has a strong possibility of going somewhere else. And so ocular oncology is what I like to think is a bridge with the rest of the oncology world, in which we have to really understand what are the conditions from elsewhere in the body that can come to the eye, what are the latest treatment options in cancer, and what are the latest treatment options we can offer our patients. So just a little bit about what ocular oncology is. It's a comprehensive care of cancerous, precancerous, and simulating conditions in and around the eye. As you can imagine, any sort of lesion in which there's a concern of possibly being cancer, we take very seriously and make sure that and rule out that it either is or is not cancer. The ocular oncology, as you can tell from this lecture series with me, Dr. Lee, and Dr. Ediriwickrema, it spans all the specialties or the subspecialties within ophthalmology. And there really only are a limited number of fully trained specialists in the country. And that's why I think there's an advantage of UC Irvine as it being a tertiary care and academic center, that there are these specialists that are sort of grouped together, which isn't the case in most places. So in terms of how we rely importance on these conditions, really, when we're eye doctors, we always think about vision as sort of the most important thing, and then eye, and then the life we don't focus on too often with most of our conditions. Most of our conditions are essentially kind of localized just for the eye. But with ocular oncology, that pyramid is turned completely upside down, and what we care about the most is life of the patient, and then followed by, if we can preserve life, then preserving the eye itself and preserving the globe. And if the first two are taken care of, life and eye, and then we can focus on the vision. So it is different when we think about tumors related to the eye. This is kind of the schema that comes across when we're treating these patients. So eye cancer is unfortunately everywhere, or it can happen anywhere in the eye. And this is a nice cross section of the eye that sort of shows the basics of it. The front part being the cornea, or the window of the eye. The center part is the lens. If you think about this like a camera, where the cornea is a lens cover, or the clear part, and then the lens is the lens, and the back part of the eye, the retina, is the film in the camera. And so really, unfortunately, eye cancer can occur anywhere along this spectrum. And this is just a schematic sort of showing the I think someone is unmuted. Okay, great. Thank you so much. So this is just a little schematic of showing where growths can occur. Dr. Lee covered this, where the surface of the eye in yellow, but other parts can be inside the front part of the eye, happening to be most likely on the iris. It can happen in the ciliary body, or more anteriorly in the back of the eye. It can happen all the way in the back of the eye, and it can happen around the eye as well. And unfortunately, eye cancers do not discriminate. We see eye cancer happening in all ages, anywhere from a newborn baby to an elderly person. It does not discriminate in terms of ethnicities. As I mentioned before, it can happen in all parts of the eye, and it also may involve the rest of the body, which is what I discussed at the beginning of the lecture. So just briefly, some of the most common cancers by age. In the childhood, we care most about retinoblastoma, which unfortunately can be a fatal disease if not treated. And this is a photo taken while the baby is asleep under anesthesia. And then we're able to take a picture of the back part of the eye, and this white mass in the retina is consistent with the retinoblastoma. For young adults, usually the most common cancers are conjunctival tumors, which Dr. Lee covered. And then in adults and not so young adults, what I'll talk about is melanoma, but we can also get lymphoma in the eye. And this is a picture, which I'll show a few more photos later, but a brown, kind of a dark pigmented lesion in the back part of the eye, which is clinically consistent with the choroidal melanoma. So really focusing on the back of the eye cancers, there are all these layers in the back of the eye, and there can be metastatic lesions that come from somewhere else in the body. Lymphoma can also present in the back of the eye, and then all sorts of little growths that are benign as well, that are not have no chance of spreading elsewhere in the body. We also follow these. And the choroid, which is the layer right underneath the retina. So if you see in the schematic here, it's pointing to the retina. The layer right underneath the retina is called the choroid. And that's where it has melanocytes, which are the melanin-containing cells that are similar to the cells on our skin, and they can cause a melanoma in the back of the eye, just like there can be a melanoma on the skin. And then a metastatic tumor can also spread to the choroid. So this is a nice schematic that kind of puts things into perspective in terms of the numbers. Cutaneous melanoma, or melanoma on the skin, is not that common, but it's not that uncommon either. There are greater than 70,000 cases per year, or an incidence of 14 per million. But then if you look at these other numbers, uveal melanoma, or uveal, which is somewhat synonymous to choroidal, there are only 6 per million, so much, much smaller, and way fewer cases as well. And then conjunctival melanoma is even rarer than that at 0.12 per million. So thinking about the numbers a little bit, melanoma is very scary, but if you think about melanoma on the skin, before a melanoma, you can just have a mole. And so another name for a mole is really a nevus. And when we look inside the eye, a high percentage of the population than what you might expect, 8% in the US have a choroidal nevus. So it's very possible that someone in the Zoom webinar has been diagnosed saying that, oh, you have a mole in the back of your eye, which was diagnosed by your eye care provider. But 8% of the population has a choroidal nevus. But then if we look at those that actually cause any issues or cause a problem, it's 1 in 9,000 will transform into a melanoma. So that means 8,999 will cause no problems at all. So, if you go to your eye care provider, and again, they say that you have a small mole in the back of your eye, you have 8,999 of the time it will not cause any issues. It's really just that one time that it would be something a little bit more concerning. So when you look at the US in epidemiological studies, there are about 2,400 new cases of choroidal melanoma that are diagnosed each year. And about a third of these are diagnosed when they're small, but that means about 2/3 of them are diagnosed when they're a little bit bigger. And there are all these staging criteria that we take into account to determine the size. So this is a photo of a choroidal melanoma. So this is a composite picture of the retina, where we're taking a picture as your eye is dilated and we're looking into the back of the eye. This is the optic nerve. So we're seeing the tip of the optic nerve enter the eye, and the optic nerve is the cable that connects the eye to the brain. In the retina, there are all these blood vessels. It's a very vascularized tissue. So you can see all these red lines here. Those are blood vessels. And if I can convince you that underneath this red blood vessel, there's this pigmented brown lesion that appears to be a growth. And this is very clinically consistent with the choroidal melanoma. So choroidal melanoma, I mentioned that it's quite rare, but it's the most common primary intraocular malignancy. As I mentioned, there are 6 per million, or 25 to 2,400 to 2,500 new cases per year. Genetically, we seem to see it a little bit more common in older Caucasians, although other races can have it as well. And it does not appear to be genetically connected to melanoma on the skin. So the genetics are completely different than what you would note on the skin. So if you have a history of a melanoma on the skin, it doesn't necessarily mean that you have a higher risk of developing a melanoma in the eye. Unfortunately, these can be quite serious, because even with our best efforts, oftentimes at diagnosis, there's a chance that some of these melanoma cells may have spread to the rest of the body, which means metastatic disease. And unfortunately, this metastatic disease is quite aggressive. Even though treatment is getting better and better with new immunotherapies and new FDA-approved treatments in the last couple of years, but at this moment, the mortality rate still is higher than what we would like it to be. So how are these tumors detected? no need to worry. You do not need any specialized equipment or anything. This can just be picked up on a routine eye exam. But you have to be dilated. You cannot pick this up without being dilated. Some eye care providers don't dilate you, but they take photos of the back of the eye, which is okay as long as the photos are highly reliable. But an optometrist, an ophthalmologist, anyone who's dilating your eyes, they can pick this up. And what we do most of the time, as I mentioned, that 8% of the population has a choroidal nevus. There's really nothing to do in those situations, but just to watch it. Just like if you'll have a small mole on your skin, we just watch it, and the dermatologist advises you to just keep an eye on it. And if it changes in size or color, or it grows or anything like that, then to be more concerned about it. Exact same thing with the back of the eye. But in this case, it would have to be an eye care provider that examines you. And then if your eye care provider is suspicious for a melanoma, then this should be referred to an ocular oncologist. Most people or most ophthalmologists do not treat these. It really has to go to an ocular oncologist, which is a specialized field. So when you come to a eye appointment, you must, understandably, these eye visits can be quite long, and that's because there's just so much imaging that we're able to do to really understand what's going on with these lesions. In many cases, it's not so clear cut that this is clinically consistent with a melanoma, so we take lots of pictures. You can see all sorts of different photos that we have here. This is another set of photos where if you see on this top row, we're taking a simple photograph here, and then we can actually take a cross section of it and see that there's a little bump or there's a little elevation in this lesion. And so we would kind of follow this, and this was reported to grow over time and over the next 6 months. And so growth was more suspicious for it being a melanoma rather than just a nevus. And so this patient was treated. So what we do is that we often observe these lesions unless it's a slam dunk diagnosis of a choroidal melanoma. And then as we observe it, if the lesion does grow in size, then that is very, very highly suspicious of a melanoma. So we have a couple of treatment options for this. In cases in which it's not so clear cut that it's a melanoma, then we can observe these and assess for growth. And the studies show that that's perfectly safe and reasonable to do. In some cases, we can do laser treatment. In some cases, we offer radiation treatment locally, which I'll discuss in a little bit. Otherwise, if we are not so sure, we can even take a sample of the lesion, and then as sort of the most invasive is that if the lesion or the tumor seems to be quite large, that wouldn't be amenable to these other treatments, then we can remove the eye. And all of this is really a multidisciplinary approach. We do this with oncologists, general oncologists, radiation oncologists, geneticists, sort of as pathologists. It's kind of a whole team approach in terms of taking care of these. So talking about radiation therapy, the most common thing that we do is a plaque brachytherapy. So in this picture right here, there are actually these radioactive seeds on, often it's a gold plated plaque. And we actually sew this onto the eye. So it's surgery in which we place it right onto the eye, right where the lesion is. And what we do is that it's custom designed for the size of the patient's tumor. There's a lot of planning involved, and that's why all those photos that I showed you before, in which we look at the tumor in different ways, are extremely important to be able to get the exact size of this. Oftentimes, we leave this on the eye for about 5 days. The patient goes home after surgery, and then they come back 5 days later, and then we remove it. And so this is just kind of a schematic. If you imagine that this blue circle is a tumor in the back of the eye, we really just sew the eye plaque, the radiation plaque, just directly underneath it so that it doesn't cause any issues elsewhere. And then the goal is that there's a radioactive field that cooks the tumor. And over time, that tumor will start to shrink in size, which would be suggestive that it was a successful treatment. So that's just a little bit of an overview of choroidal melanoma. Again, it's nothing to be too worried about. All it means is that it's always a good idea to get an annual eye exam, or just to make sure that you're getting a dilated exam, when indicated. So I'm happy to take any questions if anyone has any, or at the end of the session. Thank you.